those of us attending from the Kingston area are situated on the Anishinaabe and Haudenosaunee territories. And I've been out in BC for the last 3 weeks, and it's so nice to be back here. And I just look at this beautiful day and just want to express my gratitude for these lands and the leaves that are now almost fully out, and the tulips that are in bloom, and for the extra long day we have this long weekend to enjoy the outside. I just also want to say thank you to each of you for taking the time over the next hour to be present as we consider how our work at HSPRI can help support principles of equity, diversity, and inclusion. And today, specifically, as we listen to Dr. Flemming, how these principles can be applied to our understanding of how we support those people living with chronic health conditions and those specifically most at risk. I'm so grateful, Jen, that you're here today, and happy to introduce Dr. Jennifer Flemming, who's an associate professor of medicine and public health sciences at Queen's University. And her clinical training is in gastroenterology, hepatology, and liver transplantation. She's a clinician scientist who leads a research program that leverages Ontario administrative data that's housed here at ICS to evaluate epidemiology and the outcomes of patients with cirrhosis. And you've received a wide range of funding, which I won't go into, but from Canada and US, and most recently some great CHR funding. I'm just excited to hear today your research into the rising trend of cirrhosis in North American women. So I'll hand it over to you, Jen. Thank you.
Great. Thanks, Catherine. And thanks everybody who has managed to join in on this nice day. We're just saying how nice the weather is. So over the next about 45 minutes or so, I'm going to be reviewing the following objectives. So we're going to review the epidemiology of alcohol use disorder and alcohol-associated liver disease among women. And then we'll appreciate sex-specific differences in the natural history of ALD and understand how the impact of North American culture and COVID-19 are influencing rates of ALD specifically among women. And then we'll finish by discussing current and future strategies that may help us manage AUD and ALD among women. And as Catherine mentioned, EDI is important in what we do every day. And with respect to this lecture, I will be talking both about sex as well as gender. When I talk about biological features, I'll be talking about sex. And when I talk about the sociocultural differences between men and women, I'll be discussing gender. So this is really the only slide I'm going to have on kind of the clinical medical aspect of alcohol-associated liver disease, just to make sure the audience is aware, because it is a very diverse audience. So this just shows you that in approximately 90% of individuals who are heavy drinkers, which I'll define a little bit later, there's a development of fat or steatosis in the liver. Within a subset of these individuals, they go on to develop alcoholic steatohepatitis, which is inflammation in the liver, which leads to fibrosis. Fibrosis, which progresses in a subset of individuals, leads to cirrhosis. And once you have cirrhosis, you're at risk of liver-related complications such as decompensation and hepatocellular carcinoma. So when I explain this natural history to patients, I use the analogy that having alcohol-associated liver disease is like having a 20-year-old car. It takes a long time for damage to develop, and that happens asymptomatically until it gets to the point where your car is at risk of breaking down. On the bottom panel there, you see alcoholic hepatitis. That's a distinct clinical entity where there is severe liver dysfunction in the context of significant alcohol consumption, which can lead to liver failure and death without having cirrhosis. And the analogy I use here is if you have alcoholic hepatitis, it's like you could have a brand new car or an old car that gets in a car crash. And then the question is whether or not that car can be repaired and go back on the road, or whether you need to trade it in and get a liver transplant. But what I also want to highlight is that it's been well known in our field that female sex is significantly associated with the development of alcohol-associated liver disease. And this may seem a little bit counterintuitive, because I think that this, as well as myself sometimes, this is what we think about when we hear the term alcohol-associated liver disease. For anybody who watches the show Shameless, this is the main character, and this is what is portrayed in society as somebody with alcohol use disorder. Typically, somebody would picture a middle-aged Caucasian man with significant alcohol use disorder who may or may not be a functioning member of society. But I hope by the end of this lecture, your thought about what comes to your mind when you think about alcohol-associated liver disease might change. So I'm going to just make sure that we understand two different terms because they are related, but they are different. I want to talk about high risk drinking, and I would like to talk about alcohol use disorder. So when we talk about high risk drinking, this is defined based on the quantity of alcohol, which is associated with end organ complications. And to determine if somebody is a high risk drinker, it's usually based on the history from either patient or caregivers. In general, now these levels kind of vary sometimes depending on the sources that you look into, but in general, high risk drinking among men is when you consume more than 15 drinks per week or more than 3 drinks in one day. And for women, it's lower, more than 10 drinks a week or more than 2 drinks in one day. And when we talk about a standard drink, I have that there at the bottom. A standard drink is either 12 ounces of beer, 5 ounces of wine, so there's approximately 5 drinks in a bottle of wine, or 1.5 ounces of spirits. This is in contrast to alcohol use disorder, where AUD is actually defined based on the behaviors and the consequences of alcohol use, not how much somebody is consuming. And this is diagnosed by the presence of 2 or more of the DSM-5 criteria over the past year, which are listed there on the right-hand side. And then it's broken down to either mild, moderate, or severe alcohol use disorder. Traditionally, in medical school, nursing school, clinical training, we learned about the CAGE questionnaire, and that was an older screening test for AUD. It was easy to remember because you could remember these 4 questions, and if you asked an individual and if they had 2 or more positive responses, it had relatively good sensitivity and specificity for alcohol use disorder. However, over time, this has started to fall out of favor, and more recently, and especially in research settings, individuals now are using the audit test. So this is the alcohol users disorder identification test to screen for alcohol use disorder. And I have this outlined here on the right-hand side. So at the beginning, it talks about how often you have a drink, how many drinks do you drink in one sitting, and how often do you quote unquote binge drink or have more than 6 drinks on one occasion. And then it goes into some of the consequences surrounding alcohol use. So for instance, how often the last year have you found you were not able to stop drinking once you started? How often have you failed to do what was expected because of drinking? How often have you needed an alcoholic drink to get you going in the morning? How often have you had the feeling of guilt or regret? How often do you not remember what happened the night before when you were drinking? Have you or someone else been injured as a result of your drinking? And has a relative, friend, doctor, or healthcare professional advised you to cut down? So then you score this up and then you total it. I did my audit score. My audit score sometimes changes depending on if I'm in the summer and I'm at the cottage. I will attest to that. But currently my audit score is 3. So if you look at the bottom here, I would be in the sensible drinking category, 0 to 7. And then it increases to hazardous drinking, harmful drinking, and then possible dependence. So among those with alcohol-associated liver disease, all of them are high-risk drinkers by definition because they have end organ complications. But there's a significant overlap in those who have alcohol use disorder, but also important to know that not everybody who has alcohol-associated liver disease has alcohol use disorder. But when we look at the trends of these things, they're very tightly related, and AUD is usually comorbid in 30 to 50% of individuals who have underlying alcohol-associated liver disease. So now we're going to talk about the changing epidemiology of alcohol use, specifically among women. So I'm trying to present as much Canadian data as I have. This is from the Canadian Community Health Survey, the last one, which I believe was published in around 2018. And so it's a survey sent out to the general population to try and assess not only alcohol use, but other illicit substances. So in the last iteration, any alcohol use in our population over the past year among women was 75%. But when you look at different subgroups, for instance, those women aged 20 to 40 years, 85% of them had consumed alcohol in the past year. And past 30-day use increased from 66% to 74% from 2008 to 2017. When we look at high risk drinking, so that was based on the quantity of alcohol between 2008 and 2017, some interesting trends were found in that high risk drinking actually decreased by 10% among men, but increased by 30% among females. And the highest proportion of the population with high risk drinking were women aged 20 to 24, where it was occurring in approximately 40% of the Canadian population. When we look at alcohol use disorder, so those who are having harmful consequences of their alcohol use, in the general Canadian population, it's estimated to be about 5%. They can't really diagnose this based on the way they do the community health survey. But if you look in the United States where they have data on this, which is a little bit more teased out, 8% of women aged 18 to 25 have underlying alcohol use disorder. So this is some data that started to come out. This was Dan Mehren and his team who published this in the CMAJ several years ago, where they used ICES data and looked at presentations to the emergency department for alcohol use and looked at changes over time. And what they found was between 2003 and 2016 that overall emergency room visits for alcohol increased over fourfold. And the highest increase was among women, where ED visits from alcohol increased by 86% in contrast to 53% in men. And when they looked at the age demographic, it was most common among young adults, where ED visits from alcohol increased by 175% over the study period. When we look at the United States, this is also happening. So this was published several years ago, where they looked at rates of high-risk drinking and alcohol use disorder and compared them between 2001 and 2002 to 2012 to 2013. So when they looked among men, it was going up. High-risk drinking increased by 16% and AUD by 35%. But it was almost double that in women, where high-risk drinking increased by 58% and alcohol use disorder by 84%. So what about underlying liver disease? We published this several years ago, around the same time that Dr. Mehren had published in the CMAJ about alcohol use in young individuals. And what we did here is we were just actually looking at the epidemiology of cirrhosis in Ontario over the past several decades. And what we started to notice when the data was coming out was that young individuals were developing cirrhosis at much higher rates than others. So what this figure from this paper shows, the lines are based on your birth cohort. So the green is individuals born 1945 to 65, the red is 66 to 1980, and the blue is greater than 1980. And what we found is that at any given age, you were more likely to be diagnosed with cirrhosis if you were born in a more recent birth cohort than if you were before. And when we looked at that, we stratified it between men and women, what we found was that in those younger birth cohorts, so individuals born 1980 and 1990, although rates of cirrhosis were going up, they were much higher in women, where the confidence intervals didn't even cross those in men. So at this point in time, we weren't really sure what was driving this. We had some hypotheses, but this is what we had originally seen. So then we went on to get more funding to try and define, well, there's multiple causes of cirrhosis. Alcohol is certainly one of them. What's really driving this increase in these young birth cohorts? So this is a figure where these are just females with cirrhosis. And what we did is we were then able to define, did you have alcohol-associated liver disease based on a validated algorithm that we had developed in ICES. And then we looked at rates over time, and the younger both cohorts are there in orange and blue. And what we had seen is that in older birth cohorts, rates were going down. Those in the baby boomers were stabilizing, but they were going up in those individuals born between 1965 and greater than 1980. So then what we did is we ran some models to project, well, if nothing happens over the next 20 years, what's going to happen to rates of alcohol-associated cirrhosis among women? And this is what we found, that rates are going to continue to go up, and specifically in that younger birth cohort born after 1980. I would also like to highlight that we were just looking at individuals who had alcohol-associated cirrhosis, which is really the tip of the iceberg for all individuals who have underlying alcohol-associated liver disease. And I would also like to highlight that we base these calculations on pre-pandemic patterns. And as we'll discuss, these projections are a very modest estimate to what will happen over the next 20 years if we don't do anything. This was one of my graduate students who, since we were looking at alcohol in young individuals, we wanted to look at it in a different way. So what he had done is he had taken the SRTR database, which is a large population-based transplant database from the US, which captures all individuals who are waitlisted for all transplants, including liver. And then what we did is we stratified it based on the age that you were put on the wait list for liver transplantation. And then we stratified that based on your cause of underlying liver disease. So what this graph shows, I want to highlight the black line there. That's waitlisting for alcohol based on rates of the general population. And as you can see, by the end of 2018, alcohol-associated liver disease was the most common reason for liver transplant waitlisting among individuals aged 20 to 39, and surpassed that of autoimmune liver diseases, which has historically been the main reason for individuals to be waitlisted. And then when we stratified this analysis and looked at, was it different between men and women? It was, where rates of alcohol-associated liver disease transplant waitlisting were higher among females than they were among males. So given all of this data, the question really is, well, why is harmful alcohol use disproportionately impacting women? Men and women have access to alcohol in similar fashion. So what is changing, and why are these rates accelerating so much faster among women? And I'm going to be discussing three different aspects. So biology or sex, we'll talk about culture and policy, and that the impact of gender norms. And then we'll also talk about the impact of COVID-19. So first we'll talk about biology. It's been well known that women are at higher risk of alcohol-associated liver disease at the same quantity of alcohol compared to men. And this was a nice meta-analysis that just tries to highlight that, where they took all the studies from across the world and they looked at the relative risk of cirrhosis between men and women, and they compared that to individuals who are long-term abstainers. And the alcohol use was categorized based on if you are an occasional drinker, and then drinks per day between 1 and 7. So if you are a man, your risk of cirrhosis compared to someone who does not drink really starts to go up only in this meta-analysis once you start consuming greater than 7 drinks per day. And you contrast this to women, where the risk of cirrhosis starts to go up at even those who drink 1 drink of alcohol per day compared to long-term abstainers. And if you look at the bottom there at 7 drinks per day, the relative risk in men is 7, but the relative risk in women is almost 25. So these can be partially be explained by differences in biology or sex. And there's 4 major points that I think is important to understand. One is alcohol dehydrogenase levels, body water, estrogen, and the microbiome. So on the left-hand side, here's the typical metabolic pathway for alcohol, where alcohol dehydrogenase, or ADH, breaks down alcohol to acetaldehyde, which is further broken down to acetyl-CoA, and then CO2, water, and energy, as well as fatty acid. And this is the fatty acid that gets in the liver that starts causing all the liver damage. So this was a very old article from the New England Journal in 1990, where they looked at the presence of ADH between men and women. And in men, ADH is produced in the stomach, which can reduce the amount of alcohol absorbed by up to 30%. However, when they looked in women, there was minimal ADH production in the stomach. And therefore, for the same amount of alcohol consumed, women have a higher blood alcohol content and higher amount of alcohol and fatty acid, which is going to get to the liver. This is also exacerbated by the proportion of body water between men and women. So women have a lower percentage of body water than men, which also increases blood alcohol concentration for the same amount ingested. Estrogen is also important and likely involved in this process, as the liver is a sex hormone responsive organ, because estrogen receptors are present on multiple cells in the liver, which are involved in alcohol metabolism, inflammation, and fibrosis. So the hepatocytes are where the fat or the de novo lipogenesis occurs from alcohol use. Kupffer cells are responsible for inflammation and pro-inflammatory cytokines. And the hepatic stellate cell is what is responsible for laying down fibrosis, which leads to liver disease progression and cirrhosis. And all of these cells have estrogen receptors on them. Finally, the microbiome is basically involved in every sort of disease process, and it's also involved in alcohol-associated liver disease. And the microbiome has been shown to be strongly influenced by alcohol consumption. Animal studies also support that alcohol-related changes in the microbiome are sex-specific. This is just a representative figure from a paper down here, where it was a mouse model where they fed male and female mice alcohol and then looked at changes in the microbiome over time. And all I really want you to see is that female mice with alcohol are in red, male mice with alcohol are in blue, and you can see how different their microbiomes reacted based on alcohol consumption. So now switching over to culture and policy, and this is really where we're going to start talking about gender and how that shapes alcohol use among women. So this is, again, a meta-analysis from worldwide data showing that men and women now consume alcohol at equal rates. So on the x-axis on the bottom is the prevalence of any alcohol use in females, and on the y-axis is prevalence in men. And that red line there means that men and women are drinking at equal rates. If the blue dots are above the line, men are drinking more. If the blue dots are below the line, women are drinking more. And you can see up until approximately 1980, men were always more likely to consume alcohol than women. But you can see since 1980, which again coincides with all of these young adults in our data, that men and women are now consuming alcohol at equal rates. And because I just told you that women are more susceptible to alcohol, this is probably playing a factor in that women are just using alcohol more often than they did in the past. There's also a huge influence of targeted marketing of alcohol to women. On the left-hand side here is an historic ad where women were usually not the target of alcohol ads. They were sexualized in order to sell alcohol to men. But you can see that there's been a shift over the past 2 decades where now women are actually the target of alcohol ads, where advertisers are specifically marketing alcohol products to women so that they will buy it more. They make it pink, they make it fruity, they make it aesthetically pleasing for the female gender. There's also been changes in how alcohol has been marketed over time. So traditionally, the way that alcohol was marketed was through TV, radio, and print ad. And that had been regulated at the federal level in Canada, where all advertisements had to be reviewed by the Canadian Television Broadcasting Network. And in and around the mid 1990s, it was decided that they no longer had to oversee this, and they changed the responsibility to either self-regulation by the alcohol companies or at the provincial level. During this time, also, there's been an explosion in social media. We know that women are more frequent users of social media than are men, and now almost all alcohol marketing is going through social media as opposed to going through TV and radio. Compounding all of this is the evolving societal gender role expectations of motherhood. So in Canada in the 1970s, approximately 30 to 40% of women worked outside the home. And over the past 20 years, this has increased to where over 60% of women work outside the home. However, because of these gender expectations, women are expected to both be able to work full-time jobs outside of the home and work full-time jobs inside of the home, and are mainly responsible for child rearing and everything that goes along with maintaining the household at the same time. When we look at data from Canada, women spend more time on unpaid work than men, regardless of the level of education. And this is shown here in these graphs from Statistics Canada. So women are spending more time on housework than are men, and they are spending more time on childcare. And add this to individuals' job responsibilities too. This has created a lot of expectations and stress on women. So women in the audience may be familiar with the development over the past 20 years of what we quote unquote call this mummy wine culture, where individuals are starting to use alcohol as either a reward for all the hard work that they've done, as a coping mechanism to deal with all the things that they're juggling with, and how much time and energy it takes to parent children. So people have kind of looked at this academically. This was just published this past year. And it was a UK-based study. And what they did is they looked at advertisements and posts from 20 different alcohol companies that were posted on either Facebook or Instagram. And they looked between June 2019 and June 2020. And what they did is they looked at these ads and they evaluated whether or not they thought that they were gender targeted based on the language that was used, as well as the aesthetics of the ads. So from this study, they evaluated 2,600 advertisements. The post reached over 68 million social media users, and 87% of these ads were all gender targeted. And when they looked at which gender was being targeted, almost 60% of them were targeting women, with very few of them promoting responsible drinking. There were 6 main themes that they pulled from these ads and the ways that marketing companies would try and market alcohol to women. They used colors that were more feminine in nature. They used fashion as well as social media influencers to promote it. We talked about the bummy wine culture already and having rewards from the domestic roles that women have. It was used to promote friendship as well as romance, as well as gender equality. So these are the themes that alcohol companies are using to try and target their marketing to women. In addition to all this, in Ontario, there's been an increase in the availability of alcohol. So not only are we targeting women, there's more products, women are using social media more, but now it's much easier to get alcohol now than it was 10 years ago. So if we look at the timeline of this, there has been the expansion of alcohol sales to bookstores and movie theaters between 2011 and 2015. Doug Ford expanded alcohol sales to grocery stores in late 2015, as well as there's been expansion of LCBO convenience outlet stores. And then there's been COVID-19, which resulted in the expansion of alcohol delivery services and the lowering of the minimum pricing of alcohol by 33% for those who purchased alcohol with their food delivery. So it's much, much easier now for us to get access to alcohol than it ever has been in the past. So that segues into COVID-19. And in addition to everything else, this has just compounded everything that was already going on. So natural disasters have been linked to increased alcohol consumption, and that's well studied. It's been shown after the 9/11 terrorist attacks, the 2004 tsunami in Southeast Asia, as well as the Oklahoma City bombings. But this has also been shown in Canada. So this is data looking at alcohol sales in the early part of the pandemic. So March to June 2020, and they looked at alcohol sales and they compared that, and the historic alcohol sales are in red, and then they compared that to the COVID-19 year. So you can see there under lockdown, sales for alcohol were much higher during lockdown than they were compared to the background year. This was just published several months ago, which expanded this. So it looked at alcohol sales across Canada from March 2020 to June 2021. And as you can see, there has been increased sales over time. And when they actually calculated, alcohol sales have increased by 5.5% per month during COVID-19 compared to what would have been expected based on historic data. So people have tried to look into, well, why are people consuming more alcohol? This is data from the Canadian Centre on Substance Abuse and Addiction. And again, a lot of this comes from the early part of the lockdown. It was a survey sent where Canadians, 972 individuals were surveyed. And of those, 19% or 185 had increased their alcohol consumption during that early lockdown period. And they asked individuals, well, why are you drinking more? And there was 3 major themes that came out. One was lack of a regular schedule. And so alcohol started to creep into their daily schedule. They were bored because they were stuck at home. And the other most common one was stress. Then what they did is they looked at these responses and they broke it down by location in the country, but they also broke it down based on whether the respondents were men and women. And what I'd like to highlight here is that in this context of COVID, men were more likely to drink because they were bored, but women were almost 2 times more likely to drink because of underlying stress during the pandemic. This has also been shown in the United States. This is data, again, from the early pandemic, where they looked at levels of psychological distress there on the x-axis, and then they looked at the quantity of drinking on the y-axis, and then they stratified that between men and women. So the interesting thing is you can see for men who are in the dotted line, it didn't matter how stressed they were, they just kept drinking the same amount. But if you looked at women, that their quantity of alcohol consumption was correlated with the level of stress that they were experiencing. And this is really not new. This has been established in the literature. This is a really good review of this. I put the reference down there. And I just wanted to highlight as 3 things as an example of what has been shown, which are different between men and women and how they use alcohol. So women with 2 or more past year stressful life events were 4 times more likely to have new onset AUD compared to men, where they were 2.5 times more likely. Women were more likely to relapse into alcohol misuse in an acutely stressful situation than were men. And women report drinking more in response to unpleasant emotions and interpersonal conflict than do male counterparts. So is there differences in underlying stress levels between men and women during COVID? Well, there has been. Again, this is from the early lockdown period, but they looked at this from Stats Canada, where they looked at overall worse mental health, moderate to severe anxiety disorder, and whether individuals felt their life was extremely stressful. And although men and women were both suffering from this, women had higher levels of worse underlying mental health, anxiety, and found life extremely more stressful than did men. They've also looked at this in healthcare workers. This was a study that, it was a longitudinal cohort study, which had started about 10 years ago, where they took residents. So they recruited residents around 2007, 2009. So that would have been kind of my generation. That's when I was doing residency. And they had planned to just follow these individuals over time to look at different work-life related events. But when COVID happened, they had the unique opportunity to look at patterns of stress among these young physicians prior to COVID and then during COVID, and then they stratified it based on if you were male or female. So what they found here is that women were more likely than their male counterparts to experience issues related to loss of childcare or school closure. They were more likely to be the primary provider of children, perform the majority of household tasks, and were ones who were stuck at home working. When they adjusted for other confounding events, women were almost 3 times more likely to experience life and work balance struggles than were their male counterparts. Then they looked at symptoms of depression. And remember, they had their depression scores pre-pandemic. So you can see in this panel here, before the pandemic, depression symptoms between men and women physicians were pretty much the same. They overlapped. But during COVID, you can see women's depression scores increase. And if anything, men's actually went down. And when you put this in a regression model, adjusting for underlying confounders, women were almost 3 times more likely to be experiencing depression than their male physician counterparts. So given all this, what can we do to actually help prevent the development of alcohol-associated liver disease among women? And I like to think of alcohol as a public health issue, and that there's different ways that we can approach this. And we can approach this based on looking at primary, secondary, and tertiary prevention. When we look at primary prevention, we're looking at limiting the exposure of alcohol to the general population. Secondary prevention would be early identification and treatment of heavy drinking, alcohol use disorder, and alcohol-associated liver disease. And tertiary prevention is treatment of end-stage liver disease from alcohol. So looking first at primary prevention, I don't have time to go into each of these in great detail, but I think that I've convinced you that governmental policy and marketing have a big influence on the ability of the general population to consume alcohol. There needs to be education and knowledge of the population of the effects of alcohol. Social determinants of health, I didn't get a chance to go into this in detail. I could do a whole talk on that and its relationship with alcohol use and alcohol use disorder. And because comorbid mental health is very tightly related to alcohol use disorder and alcohol-associated liver disease, this needs to be treated, especially women that I see, at least in the liver clinic, which is a biased population. Many women are using alcohol in excess in order to try and deal with symptoms related to untreated mental health. And then finally, low-risk drinking guidelines from authorities. So Canada's low-risk drinking guidelines are actually currently in the process of being redeveloped. And this has happened in multiple other countries, such as UK, Australia, and the United States has recently updated their guidelines as well. Within this process, they are specifically focusing on women and alcohol and having focus groups related to this, and they're planning to do a literature review from a sex and gender perspective. Most of the other countries have now changed their low-risk drinking guidelines for women to say no more than 1 drink per day. So my assumption is that something similar will happen in Canada, but we have to wait and see what the final recommendation is. From my point of view, our team has received a CHR Catalyst grant to look at the epidemiology and liver-related outcomes of harmful alcohol use among adolescents and young adults, really to try and better characterize who this population is, what sort of outcomes they're having, and looking at sex-specific differences in individuals who develop alcohol-associated liver disease to determine strategies in order to target this population, as liver disease is the most common end organ complication from alcohol. When we look at secondary prevention, one thing that in the liver world is starting to happen is the combination of hepatology and addictions clinics. So for instance, when I'm in liver clinic right now and I see a young woman who has liver failure from alcohol and has underlying alcohol use disorder, I can treat her symptoms of liver failure, but I have a very hard time treating her underlying alcohol use disorder, as there are very few community programs to refer individuals to, and there are many complex situations that women are in which make it much harder for them to participate in alcohol use disorder programs, which I didn't have time to go into today. Again, we need to be screening for alcohol use disorder and ALD potentially at the level of the general population, and we need to be promoting modifiable risk factors among women who consume alcohol to try and decrease the risk of developing liver disease. So the U.S. Preventative Task Force actually has a recommendation out that recommends screening for harmful alcohol use at the level of primary care in adults and pregnant women with the audit score. The screening, brief intervention, and referral has been recommended by the OMA, PHO, and the Canadian College of Family Physicians. There has been no recommendation made by the Canadian Task Force on Preventative Health Care, however, which is probably the most influential body with respect to public health guidelines. In Ontario, it's difficult to screen for harmful alcohol use and its effect on the liver. AST, which is a liver enzyme which was strongly related to alcohol use, has been decided that it must be paid for by patients, and it's only covered if ordered by a specialist. And therefore, primary care has a very difficult time trying to determine whether individuals with high-risk drinking have underlying alcohol-associated liver disease. They're unable to risk stratify patients because the AST is used in all of our non-invasive fibrosis testing to try and figure out, does this person have advanced liver disease or cirrhosis? And FibroScan, which is the machine that we have in our specialty clinic in order to try and diagnose cirrhosis, is currently only accessible at the level of specialty care, with wait lists into our clinic of over 2 years. There have been modifiable risk factors for the development of alcohol-associated liver disease among women, which I think is important if you're seeing these patients in your practice. This is based on a prospective cohort study, the UK Million Women study. Some of you may be familiar with this, where they enrolled 1.3 million women in the UK. They were aged 50 to 64, so not encompassing the whole spectrum of females. But they were recruited between 96 and 2001 and followed until 2017. They had survey data on alcohol use as well as mealtime patterns with alcohol consumption at year 3. And what they did is they looked at the type, quantity, and frequency of alcohol recorded. They considered individuals who had less than 1 drink per week to be a non-drinker, and those who reported never using alcohol were excluded from this study. So with what they did is they linked that cohort to the NHS, and then they looked for the outcome of cirrhosis using ICD coding. So as we all know, the risk of cirrhosis is higher if you consume more alcohol. So what they did here is they looked at the relative risk of cirrhosis among women who consumed alcohol and compared those who had more than 15 drinks per week to those who had 1 to 2. And the risk of cirrhosis was over 3-fold higher with that quantity of alcohol. So one recommendation, and again, this is why I think the Canadian, the healthy drinking guidelines are probably going to change for recommendations for women to consume no more than 1 alcohol drink per week. It has also been shown that your risk of cirrhosis is related to whether you are a daily drinker versus a non-daily drinker. So again, within this study, they took individuals who consumed at least 7 drinks per week, but they looked at those who consumed all of their drinks in kind of bolus fashion versus those who drank every day. And what they found was that in women who consumed daily compared to women who consumed less than daily, that the risk was 60% higher if you were a daily drinker. So again, if you are counseling women who are using alcohol, another recommendation would be to not drink alcohol every day. There's the risk of cirrhosis is also lower if you consume your alcohol with meals. Again, what they did is they took individuals who had the same quantity overall of alcohol consumption, but then stratified that to whether or not you drank with meals or without. And if you drank with meals, which is in the red bar, your risk of cirrhosis was lower compared to if you drank outside of meals, and lowered your risk by approximately 30% after they accounted for confounding. So these would be tips that could be used at the level of primary care to help reduce the risk of developing end-stage liver disease. Now, finally, tertiary prevention. So this is kind of an area of focus within hepatology specifically, and specifically equal access to liver transplantation for alcohol-associated liver disease is a big issue, as it's been well documented that men are much more likely to receive liver transplantation than are women. There's other things that I had mentioned before, so the combination of hepatology and addictions clinics, and I think that the field is now moving in that when we do trials in alcohol-associated liver disease, that we need to use a sex and gender approach because of all the reasons that I highlighted before, that alcohol use on the liver has a different natural history between men and women. And again, cornerstone to all of this is access to mental health treatment. I'm going to end by just saying, highlighting one thing that has been shifting in the hepatology community related to this. So people are probably unfamiliar unless you deal with patients with liver disease, but the MELD score is the score that we use, which prioritizes patients on the liver transplant wait list. And historically, these were the 4 components of the MELD. So the bilirubin, INR, sodium, and creatinine. And if you look at the actual derivation of the MELD score, it was derived in all men. And so not unexpectedly over the past 20 years, this is at least one of the factors which has led to lower rates of liver transplantation among women as compared to men. So this was recently updated to include these 2 other variables, one of which was sex as well as albumin. And what these investigators showed that compared to the MELD sodium, which is what we historically use to prioritize for transplantation, the MELD 3.0 improves prediction of waitlist mortality and reclassified 9% of patients with a significantly higher chance of transplantation for women. So we're making slow steps, but I think things are headed in the right direction. So in summary, rates of alcohol use disorder and alcohol-associated liver disease are skyrocketing among women. And the reasons for this are multifactorial and related to biology, culture, policy, and COVID-19. And efforts to improve primary, secondary, and tertiary prevention of AUD and ALD are needed to reverse these trends for future generations. And with that, I'm happy to take questions or have a discussion. Thank you.
Thanks, Jennifer. That was outstanding. I learned something, lots. You can either put your questions in the chat or raise your hand, and we can go from there. While people are thinking, I've got one. Given the increased prevalence and incidence in women, are there early biomarkers that would indicate the alcohol use disorder is impacting liver function earlier on than getting liver disease?
Yeah, I mean, that's a good question. As far as I know, there's obviously nothing in clinical practice, whether or not people are looking at some of those. I mean, there's lots of different non-invasive ways we try and diagnose liver disease. But I think an essential thing is that, you know, as I highlighted, primary care can't even screen for it using our regular testing that we do because of the province pulling away AST and saying that it wasn't needed in order to care for patients. And so that is disproportionately impacting patients with liver disease in general, and specifically alcohol-associated liver disease, because right now what the government says is they'll pay for the ALT, but not the AST. But if you spend a lot of time with individuals with alcohol-associated liver disease like I do, very commonly only the AST will be elevated and the ALT will be normal. So you're not going to be able to identify individuals even using our standard testing, let alone using anything a bit fancier. So the liver community is trying to advocate to the government, well, why did you do this? And we can't care for patients with liver disease because of this. If you want to get rid of something, get rid of the GGT. We don't care about that. Please give us the AST back. And the majority of patients who have underlying liver disease because of their social determinants of health don't have the ability to pay the extra money in order to get an AST. So it's really, and in conjunction with everything else I said, we're not going to be able to identify these patients until they're late and they show up with liver failure if we don't have access to even basic testing.
Yeah. Interesting. Is there anything in the literature among women that looks at the quality of one's diet or stress when I think of some of the eating patterns where there's a lot of processed foods and they're not eating well? Does that one increase the alcohol effects? Does it?
Yeah, so that's a good question. We know that you can easily have more than one liver disease. And the other epidemic of liver disease is non-alcoholic fatty liver disease, which is related to our diet, exercise, obesity, all of that stuff. I didn't have time to go into it, but if you look at individuals, especially the younger generation, because they have higher rates of obesity than previous, plus they're consuming alcohol at higher rates. So, I mean, I've seen patients who are 20 years old who come in with cirrhosis and liver failure. And it's a lot of them have this phenotype of having probably both alcohol associated liver disease and non-alcohol associated liver disease. So I think that's a whole other aspect of it that is probably leading to higher rates of alcohol or liver disease, especially among younger individuals. There's a lot of individuals who have underlying hepatitis B and C, which are comorbid with underlying alcohol use disorder. And those individuals are much more likely to have a more rapid progression to liver disease. And the unfortunate thing is, or the fortunate thing is, it's so easy for me to cure hepatitis C. I can cure you like that. That's not the issue. It's dealing with the underlying alcohol use disorder. And because it's so intertwined with mental health, social determinants of health, I say sometimes that we should treat alcohol use disorder like cancer and have centers where people go to get assessed, and there's treatment programs and there's, stages that people go through and work through. I mean, the amount of people who have underlying alcohol use disorder in our population is maybe even higher than the proportion who has underlying cancer. And we have all these great ways, we have nurse navigators, we have, people to facilitate people's journey with cancer. We have nobody to facilitate anybody's journey with underlying alcohol use disorder. And it's very sad.
Good point. There's, Charles has a question in the chat. Charles, do you want me to read it out or do you want to?
No, I'm happy to.
Okay, go ahead, please.
That was an amazing talk, Jen. I really enjoyed it. I've heard parts of it before. So my question actually, it's a little bit about the hidden epidemic aspect of this. And I just wonder about drinking, whether some of your data presumably relies on self-reporting because you're not going to be privy in people's homes. How reliable is self-reported drinking? And is there a difference between the reliability of male and female self-reporting? Because I know if my wife and I both took that test, I reckon my wife would over-report out of an abundance of caution, and I would probably under-report because I don't want you to find out. So I wonder whether that actually spills out and how you control for that.
Yeah, so I think those are good questions. Thanks, Charlie. So I think I'll tell you a bit about how we define alcohol-associated cirrhosis in the data, because I think this is a gross underestimate, right? So the way that we define alcohol-associated cirrhosis is we find codes for cirrhosis. And then once somebody has cirrhosis, we have this algorithm that we go through to rule out other causes. So if you have hepatitis B and C, we kick you out. You could have underlying comorbid alcohol use disorder and alcohol-associated liver disease. We're not going to pick you up. Then we rule out all the other things like genetic, autoimmune conditions, that sort of thing. And then we get down, and if we find codes within the data for presentation to healthcare related to alcohol, that's how we label it alcohol-associated liver disease. So we're not going to capture people who are consuming alcohol who have never presented to the emergency room, things like that. So we're seeing kind of the worst of the worst. And I'm sure that there's a subpopulation that we're not getting, and especially those high functioning individuals who are consuming alcohol, but aren't having it necessarily affect their life to the point where they're seeking healthcare for alcohol associated problems. And that's why I showed that over that about 50% of people have alcohol use disorder, but you can have very high functioning individuals who have high risk drinking, who you wouldn't necessarily label in those categories, but it's leading to underlying liver disease.
Aisha, I'm sorry, go ahead.
No worries, thanks. I found this talk super interesting, and I was kind of wondering about your thoughts on how to tackle, the social aspects of this, because I know you mentioned like mommy wine culture and stuff like that, and that is so prevalent. Like I was up at the farmers market on the weekend, and they're selling T-shirts with those kind of gimmicky things on them. And you mentioned how this is something that's like as prevalent in society as issues like cancer, but for some reason people don't seem to take it as seriously. So I'm wondering what your thoughts are on how to approach that. Like, do you think we shouldn't be allowed to be selling this stuff? Do you think we need warning labels like we have on cigarettes and stuff like that? Yeah, I'd be interested to hear.
Yeah, I mean, it's a really good question, right? Because alcohol is so entrenched in our society, right? Like 75% of all Canadians use alcohol at least yearly. And we use it for celebrations. We use, all that stuff. And, don't get me wrong, I'm not an alcohol abstainer. Like I do use alcohol as well. And I think the issue is that I think society doesn't necessarily see alcohol as being as harmful as everything else. Like everyone's like, oh, tobacco's bad, the opioid crisis, that's bad, but more people die every day from alcohol than they do of any of those other substances. So, I mean, a lot of people have suggested that we need to start dealing with alcohol like we did with tobacco, and start really highlighting the harmful effects and trying to protect the society from the harm as best we can. And you have to do that through like a multiple public health thing. So, there's things that I had mentioned. So marketing, policy, you can just go to any corner store now and get alcohol at any time of the day. You can have it delivered to your house. You just pick up the phone and call, and like alcohol is right there. So those sorts of things on the big public health level, I think need to be tackled, but you have to have people who are advocates for it and people who find it important. And because of the social determinants of health of a lot of patients with underlying alcohol use disorder and liver disease, and when you work in clinics like I do with patients with liver disease, they never advocate for themselves. They never even tell their family they have liver disease. Everybody's embarrassed. Nobody talks about it. So you have no champion for this as you do for other disease sites like cancer, where people will come out and say, this is a problem. This is what, we have to do something about this. There's no liver champion. And people in the general public don't even know about liver disease. And if I said to probably the audience here, I said cirrhosis, everyone would probably assume it's all from alcohol, but it's not. And probably everyone would assume it's like Frank from Shameless, but it's not. Like the amount of young people, especially since COVID, that are coming in with liver failure is just so sad. And I have nowhere to help them. But if I want somebody to get help for some very subspecialized condition, there's all these clinics and everything that you can help. But my poor patients, like they have nobody to go to, and they have social determinants of health, which put barriers up for them. A lot of patients, if they have the financial means, can pay to go to alcohol rehabilitation, but that's the very slim proportion of the population that I would see, and that the majority of them have unstable housing, are living in poverty, and are victims of mental health or trauma or interpersonal or violence. So I mean, there's all sorts of intertwining of all of this, and so there's many aspects that need to be tackled.
I'm just trying to unmute there. Sorry about that. I have a question about the cost to healthcare in the province, and is there a way that you can use your study and projects to help us better understand? When I say us, the general population, the government, et cetera, how much we waste or have to use to create a better situation for those who are living with alcohol in this way.
Yeah. I think that's really important as it comes to, you know, trying to convince policymakers that this is a problem. We published a paper last year where we specifically looked at young adults with cirrhosis. So we took individuals who were aged 18 to 40, and we looked at their underlying healthcare utilization and costs of healthcare. And then we stratified that based on their underlying cause of liver disease. And overwhelmingly, the individuals with alcohol-associated liver disease were using the most resources because they were in hospital because they were so sick. So the average inpatient stay for an individual with alcohol-associated cirrhosis who was between the ages of 20 and 40 was like $20,000 per hospital stay. And, you know, all of this theoretically, in theory, is preventable, right? Like if you do not use alcohol, you cannot develop alcohol-associated liver disease. And if you looked at the rates skyrocketing, I mean, there's other data even from Alberta showing, you know, rates going up and the impact of the pandemic. And, you know, Dan Mirren's work in Ottawa showing all, you know, I think it would be hard for policymakers not to look at it, but you know, it's also such a ethical dilemma because the government gets money from selling alcohol, right? But I don't think it offsets the amount that it costs society to take care of these patients who have alcohol-associated disease. And like I said, no one's advocating for them; they don't advocate for themselves, and so it just sits as this silent epidemic that nobody's doing anything. We don't even have like an addictions team in the hospital, right? Like, you know, we have the diabetes nurse. If someone is admitted with diabetes, the diabetes nurse comes and helps. And you know, we have nobody. We had a addictions team for a very short period of time, and then I don't know what happened to it. The funding went and it's gone, and there's nothing.
Well, as you say, the government makes money from the sale of alcohol, and as you also said, it probably doesn't offset. I think the thing that's most distressing about what you it's a great talk, don't get me wrong, is I have a 27-year-old and a 30-year-old daughter. And I would argue that, yeah, they probably do use more alcohol than a lot of people. And they're being marketed to in the ways that you've suggested. It's going to be difficult to turn the tide on that unless you can stop people from advertising directly to them.
Yeah, it's there's no great solutions. I see in the chat there, Ed McNally asked about the price of alcohol. And certainly that has been shown in many countries across the world, like the UK in particular, where they increased the minimum pricing of alcohol and had showed over time that they decreased alcohol-associated deaths. And there was recent studies coming out from the United States suggesting the same thing, that if they look because there's state-to-state variability in the minimum pricing, and those who had, you know, more tight regulation on alcohol had less alcohol deaths compared to states that had it more open. So, I mean, that's certainly a big policy change that could impact outcomes.
Okay, sure. I'm just conscious of time. Sherry had another comment in the chat about incentives and the use of marijuana, but Jennifer, thank you very much. A very informative talk, and we look forward to hearing more when your grants are, when your studies are done.
Okay, great. Well, thanks for everybody for listening on this lovely day.
Okay, bye-bye, everyone.
Bye.
Bye, everyone. Thanks so much, Jen.